Welcome to the Nexus. In this video, we're going to talk about heparin. All right, so we'll talk about a mechanism of action, indications, contraindications, side effects. Right, so I hope you enjoy this video.
Heparin is one of the most commonly used anticoagulants worldwide. So what are anticoagulants? These are drugs that interfere with formation of blood clots. Blood clotting is very important. Let's say you have an injury on the blood vessel. Without coagulation, you can actually bleed to the point of losing consciousness or actually dying, right? So blood clotting is important, right, as you can see on this diagram. But there are other conditions where we need to stop this coagulation process, right? So I would tell you about those conditions because they're actually indications for drugs like heparin, right? So anticoagulants will either interfere with the action of coagulation factors or they may interfere with the synthesis of coagulation factors. So anticoagulants are used to treat thrombotic disorders such as deep vein thrombosis, DVT, and pulmonary embolism, PE. All right, so treatment of PE and DVT with anticoagulants has three main aims. Number one is to reduce the development of thrombi and emboli. Number two is to reduce morbidity from acute attacks. This can happen like in the coronary arteries or in the cerebral vessels. They can actually these events can actually cause sudden death, right? So you need to reduce morbidity. And number three is to restore patterns to the circulation, right? So anticoagulants are used to treat venous thromboembolism, while antiplatelet therapy, right? So we'll talk about antiplatelets later, but antiplatelets are used for prophylaxis and the treatment of arterial thrombi and pulmonary embolism, right? So anticoagulants is venous thromboembolism, and antiplatelet drugs are for arterial thrombi and PE. Right, so let's talk about heparin, right? So heparin is a large sulfated polysaccharide, which is usually obtained from porcine intestines, that's pigs, and bovine lungs, that's cows, right? So it is normally found complexed to histamine in mast cells, and its role in this form is actually unknown. Heparin is a strongly acidic because of the presence of sulfate and carboxylic acid groups, right? So it is administered both orally and subcutaneously, but subcutaneous route is associated with a long onset of action, right? For example, the heparin's elimination half-life is 40 to 90 minutes. What is half-life? Half-life is like the time needed for the half of the concentration of the drug to be metabolized, right? Heparin demonstrates biphasic elimination, right? So there is a first rapid elimination owing to two processes, right? So the first process is saturable fast process that involves binding of heparin to sites on endothelial cells and macrophages. And the second phase is an unsaturable process that include renal excretion. At high doses, the saturable fast process are saturated and the elimination of the drug relies on slow processes, right? So this is what prolongs heparin's half-life, right? So heparin exists in two forms. There is high molecular weight heparin and low molecular weight heparin, right? So let's start with a high molecular weight. It's also known as unfractionated heparin, right? So this is a traditional form of heparin given for treatment, and it has a molecular weight of 15,000 to 30,000 Dalton. It prevents formation of thrombi and extension of existing thrombi. It is especially used when rapid short-term effects are required, and at full dose, the unfractionated heparin can treat deep vein thrombosis and pulmonary embolism. It is also used for anticoagulation throughout the open heart surgery and treatment of acute myocardial infarction and unstable angina pectoris. Right, so at prophylactic subcutaneous doses, it is used as a prophylactic against deep vein thrombosis and pulmonary embolism following stroke, surgery, and myocardial infarction. Unfractionated heparin requires monitoring due to its sequelae and is monitored only in hospital, right? So this drug is only monitored in hospital, right? So it can only be used in inpatient settings. So for outpatient, you need, guess, low molecular weight. I will tell you what exactly, right? So here you have your low molecular weight heparin. It's called the fractionated heparin. Why fractionated, right? So this is a more modern form of heparin made from the cleavage of the traditional heparin molecules into smaller ones by chemical or enzymatic degradation. That's why it's fractionated. It was developed after the unfractionated form of heparin was found to have drawbacks such as heparin-induced thrombocytopenia, which causes a hypercoagulable state, right? So we have more time talking about the hits, right? So stay tuned. If you are enjoying this video, please make sure you give it a thumbs up, right? Let's proceed. Low molecular weight heparin is used for treatment and prophylaxis of DVT and pulmonary embolism. It is an infrequent dosage intervals and is administered subcutaneously, right? So monitoring here in this case is not necessary, so it can be taken by the patient at home, right? Outpatient. The examples of fractionated heparin include the following: enoxaparin, dalteparin, and nadroparin. The onset of action is immediate after administration, right? Next, we'll talk about the mechanism of action, right? So there is antithrombin 3, right? So this is important. In this case, let's say it's inactive. And on attaching to an example of or any form of heparin, right, using the unique polysaccharides that are found on the heparin molecule, this will activate antithrombin 3, and antithrombin 3 has a tendency of inhibiting coagulation factors, especially factor 10, active form of factor 10, right? So heparin acts as a cofactor for antithrombin 3, which irreversibly binds and deactivate factor 2, factor 9, factor 10, factor 11, and factor 12, right? The active forms. It mainly acts on factor 10, the active form, thus inhibiting the activation of the common pathway of the coagulation cascade, right? So in the presence of heparin, antithrombin 3 acts like 1,000 times faster and acts on preformed coagulants, right? So therefore, its effects are immediate. Fractionated heparin has the same mechanism of action as unfractionated heparin, but it is more selective in that it fails to affect thrombin, thus factor 2A. It is therefore less likely to activate resting platelets. Only about 1/3 of molecules in the heparin preparation are active because not all heparin molecules have the pentameric structure required to bind to antithrombin with high affinity. The action of heparin can be monitored using activated partial thromboplastin time, right? So remember which kind of heparin needs monitoring. It's unfractionated, right? So in heparin therapy, the APTT should be 1.5 to 2.5 times greater than normal. The monitoring of low molecular weight is usually unnecessary, as I said, because its pharmacokinetics are very predictable, right? The monitoring is done so that you prevent excessive bleeding in patients, and in the event that the patient will start bleeding excessively, you administer a drug called protamine sulfate. I will tell you more about this drug later, but for now, just need to know that it's a basic substance that neutralizes the acidic heparin. Right, so some of the preparations available in hospitals and in pharmacies is heparin sodium. Right, so heparin sodium is used for prophylaxis and treatment for thromboembolism. This drug does not cross the placenta, so it is safe to use during pregnancy. It is contraindicated in patients with known hypersensitivity to the drug. It interacts with antiplatelet drugs such as aspirin, NSAIDs, dextran, and clopidogrel. This drug is given either intravenously or subcutaneously, and 5,000 international units is given as a bolus injection, followed by subsequent doses given as IV infusions, 30,000 to 35,000 international units daily, right? So this is the initial dose, right? Okay. Alternatively, you can give intermittent injections of 5,000 to 10,000 international units daily. For prophylaxis, you administer 5,000 international units every 8 to 12 hours. For pediatrics, you infuse intravenously initially at 50 international units per kilogram of the body weight, and then 100 international units per kilogram of body weight, like every 4 to 6 hours. When using concurrently with warfarin, heparin should be withdrawn once effective anticoagulation has been achieved, right? So sometimes it's used together with warfarin, which we're going to talk about next, because warfarin it doesn't act immediately. So you give the patient together, and the moment you start to see the patient improving, then you stop giving heparin. It means by that time warfarin will begin to kick in. The second drug is enoxaparin sodium. Right, so this is fractionated heparin administered with an undefector 10A as to undefector 2A in the ratio of 3:1. It is used for prevention of post-operative deep vein thrombosis and embolism in high-risk patients. Enoxaparin is given at a dose of 30 milligrams twice daily or 40 milligrams once daily. Full dose enoxaparin is 1 milligram per kg subcutaneously every 12 hours. The adverse effects and contraindications are similar to those in unfractionated heparin. I will talk more about these side effects and contraindications towards the end of this video, so stay tuned. Unfractionated heparin is monitored using either protamine titration or measurement of undefector 10A units. The plasma level required to prevent pulmonary emboli is 0.2 to 0.4 units per ml, or that's protamine titration, or 0.3 to 0.7 units per ml, that's undefector 10A units. This usually correlates to an activated partial thromboplastin time value of 2 to 3 times baseline, although the use of APTT to monitor heparin therapy is problematic, as there is no standardization scheme for APTT as there is for PT, that's INR, right? Now let's talk about the adverse effects of heparin. The major adverse effect of heparin is bleeding. Heparin also causes hypersensitivity reactions like fever, chills, urticaria, and anaphylactic shock. It can also cause mild thrombocytopenia, skin necrosis at the site of injection. Other effects include impaired coagulation, renal failure, severe hepatic disease, and active intestinal bleeding. Long-term heparin therapy is associated with osteoporosis and spontaneous fractures. It also causes hypoaldosteronism, although this is uncommon. Right, heparin-induced thrombocytopenia as one of the main side effects, right? So this is a systemic hypercoagulable state that results from heparin therapy. It occurs in 1 to 4% of the patients treated with unfractionated heparin for at least 7 days. It is more common in patients treated with a bovine heparin as opposed to porcine heparin. In this disease, heparin platelet factor complexes will act as target for IgA and IgM antibodies, and the resulting immune complexes will bind to Fc receptors on the platelets and resulting in activation. All right. The activated platelets are therefore more likely to bind to each other, thus stimulating the formation of floating platelet aggregations that could precipitate in venous structures and form thrombi. Despite this state being a hypercoagulable state, the condition is a consumptive coagulopathy, right? So we are consuming the platelets, so the person will have thrombocytopenia. The venous thrombosis is more common, and for this reason, patients on heparin should receive frequent platelet counts. Heparin-induced thrombocytopenia is treated by discontinuing heparin and administering a direct thrombin inhibitor or danaparoid. And this scheme shows what I just explained, right? So you can see these are complexes, these are platelet complexes, right? So they are removed by the splenic macrophages. So as a result, we have thrombocytopenia. What also can happen is activation of platelets, and this can lead to platelet release and platelet aggregation, which leads to thrombosis. Another pathway is release of procoagulant microparticles, leading to thrombosis as well. Right, so there are two types of heparin-induced thrombocytopenia, type 1 and type 2. HIT type 1 is a mild, transient, non-immunologic drop in platelets count that typically occurs within 2 days of heparin administration. And this type is not clinically significant. As you can see, the number of platelets at this stage is actually more than 100,000 per cubic millimeter. Type 2, however, this one is more dangerous. This is the development of IgG antibodies against the heparin-bound platelets factor, right? That's PF4. That typically occurs 5 to 10 days after heparin administration. So previously I said 7 days is within this range, but if you take 5 to 10, right, this will be perfect. The antibody heparin PF4 complex bind and activate platelets, leading to removal of macrophages and thrombosis, leading to low platelet count. Right, so in summary, what are the adverse drug reactions of heparin? Bleeding, and in bleeding, I said we reverse by protamine sulfate. Osteoporosis, this happens with long-term use. Another side effect is alopecia, hair loss. Drug interactions, right? So I mentioned this before, right? So this drug heparin can actually interact with drugs that increases bleeding, for example, aspirin, clopidogrel, warfarin. Also, NSAIDs such as ibuprofen, naproxen, diclofenac, and others. Right, so this will add up to the effect of heparin and further increase the risk of bleeding that is associated with heparin. This was the main one, heparin-induced thrombocytopenia, right? So I hope you understood this concept. What are the contraindications of heparin? Because in some cases, heparin is not allowed, or you need to think of other anticoagulants like warfarin, right? So the contraindications include the following: patients who are hypersensitive to the drug, patients who are actively bleeding, patients who have hemophilia, patients who have severe hypertension, patients with ulcerative lesions on the GIT, and patients who have threatened abortion. Right, as I said, protamine sulfate, I only mentioned it in passing, right? So it reverses the action of heparin. It is a highly basic positive charged peptide that forms an ionic complex with heparin and therefore inhibiting its activity. For every 100 units of heparin remaining in the patient, you should give 1 milligram of protamine sulfate intravenously, right? So for every 100 units of heparin, 1 milligram of protamine sulfate. Infusion rate of protamine sulfate should not exceed 50 milligrams in any 10-minute period, because this will cause anticoagulant effect if we give excessive protamine.
Thank you for watching this video. I hope it was helpful. Please make sure you subscribe, leave a comment in the comment section, and share with us.